Thanks very much, Tanaka-sensei. It's great to be here in Tokyo. I've subtitled my talk from local to global and back again, and you'll see what I mean in a second. I don't have to tell you that it's quite a difficult moment in global health at the moment, and so I thought it was important to tell a story of some good news and hope, at least to start with. So this is a much younger version of Justin. The date was 2010. The person I'm handing, actually it's a little doll made by people living with HIV in South Africa where I'd been working, is Michel Sidibe, who was at the time Executive Director of UNAIDS. In the back is Bill Botel, who was one of the architects of Australia's response to HIV and AIDS in the 1980s. And we had a community reception for Michel Sidibe at one of the gay bars in the gay area of Sydney. And he said something to us which was quite shocking. And he said is that what I want is that the city of Sydney will have 0 new infections by 2015. And I want you to take that as your new challenge, your new motto, and your new goal. If we can make it to 0, that will demonstrate that we have a city free of new HIV infections and that it's possible. And we all looked at him like he was kind of crazy, because this was, remember, before PrEP, before treatment as prevention, before, or maybe that's not true, but before U equals U. And so we didn't really feel that we had the tools to do what he had set as our goal. But it did change something in us, and we realized that we couldn't keep going business as usual. The government realized they had to do something different. The community and the civil society organizations realized we needed to do something different. So how did we do? I will tell you in a second, but first, as a detour, I want to tell you about Sydney demographics, because HIV in Australia, as in many parts of the world and in Japan, is largely dominated by gay bisexual men who have sex with men. Of course, there are other demographics, but it's more than 75% MSM. And so the orange area, what we're really talking about as Sydney, is the area where more than 20% of men in the identify as gay. So that's quite a high proportion. You can see we have rainbow crossings. The pink thing on the right is actually an 18-meter high condom, which we erected in the middle of the park in the city. That was my organization, the AIDS Council, responsible for, with the permission of the council, of course, to raise awareness. And I should thank for this slide and the next, and acknowledge my colleague, Professor Andrew Grulich. These are from his IIS plenary presentation, and I couldn't have said it better myself. So what we're talking about when we talk about reducing notifications in Sydney, really I'm talking about the orange area, right? It's where most of the people, it was the epicenter of the epidemic in the 1980s. And this is how we did. You can see that from, call it 2010 levels, the area from 2008 to 2012 to 2022, there was an 88% reduction in notifications of HIV in that area. Not quite so good as you move further out, but still noticeable. And so the number of notifications, this is not AIDS deaths, this is not AIDS cases, this is HIV notifications. In the areas at the epicenter of the epidemic was 11, nearly single digits. So the moral really is that with all the tools that we have today, we can get to the UNAIDS targets of virtual elimination of transmission, defined as a 90% reduction. Of course you need resources, and of course you need political and community alignment, all of that, we can do it. So that's my relatively good news story. And I promised I would move from local to global. Before I do that, let me say why I think we were successful. First of all, there was a strong government commitment, and we had a determined health minister who wouldn't take no for an answer and said, we're going to do this. And that government commitment is critical. We had a really rapid rollout of pre-exposure prophylaxis. First, a large-scale implementation trial with our colleagues at the Kirby Institute. We got 10,000 men onto PrEP very quickly. And then a couple of years later, in 2018, PrEP was listed on our pharmaceutical benefit scheme, meaning it was readily and affordably accessible. There was an important partnership which persisted from the early days of the AIDS epidemic between politicians, policymakers, all those people you can see, but critically communities, and this was a community-led response with well-funded community organizations that I'll say more about. And really it is these community organizations who are the last mile, who can reach the people who need to be reached. So now onto this global perspective, because of course stories like what has been happening in Sydney has happened across the world, but in the context of a much broader movement in the global health sphere. And so between 2010 and well, now we've had the introduction of the Sustainable Development Goals, and SDG 3, as you know, is around ensuring healthy lives and promoting well-being for all at all ages. There is this goal, SDG 3.3, about ending the epidemics of AIDS and the other epidemics, which I won't name individually. But then this is also this goal, SDG 3.8, about universal health coverage, including financial risk protection and so on. And so that's much more broadly than on specific diseases, about health systems in general. And because of that, it's kind of seen as the umbrella goal of the SDGs. A reminder, and again, Tanaka-sensei did a good job of this, but when we talk about UHC, we mean that all people have access to the full range of quality health services they need, where and when they need them, without financial hardship. It covers the full continuum of essential health services, health promotion, prevention, treatment, rehabilitation, and palliation. And so there's these two arms. There's the service provision, but there's also financial protection. So people shouldn't be pushed into financial hardship to access the health services they need. And we often talk about the UHC cube. And on one axis, you might call it the x-axis, or the A that you can see on that diagram. There's the question of who is covered. And this is really the equity dimension, making sure that the people in the most vulnerable and marginalized situations are also included. On the Y, or the B axis, there's the question of which services are covered, because of course no government can cover every service, and so we have this talk about essential benefits packages. And then along the Z axis, I'm a mathematician, you can tell, or where it says C, is the question of who pays for it and how do we pay for it. And the idea is, how do you maximize the volume of that blue cube to cover as much as you can? And it's critical to remember each of these three dimensions, because sometimes when people talk about UHC, they're really only talking about one of them, a point I'll make in a second. I'm not going to talk about this slide. I put it in there because I wanted, in case you wanted to come back and look at it later, these presentations will be available. But just to say, this movement really started with the declaration of Alma Ata in 1978 on primary health care. And while there was huge and significant progress on individual diseases, including HIV in the sort of 2000s, the Millennium Development Goal era, people gradually realized that we don't know what's next, whether it's Ebola, whether it's COVID-19, whether it's Mpox. And so the way to address whatever comes next is not to go necessarily disease by disease by disease, but to strengthen and build equitable and resilient health systems ready for whatever is next. And the global status, I will let you read these and come back to them later, is that we're quite far off course. Basically half the world has the access to the services they need, and about 2 billion people continue to face financial hardship. Obviously COVID-19 was deleterious, made things much more difficult, and the recent suspensions in official development assistance have caused significant disruptions. Here I say, as of March, April this year, in about 70% of countries with WHO country offices. So it's a challenging situation. It is important to call out Japanese leadership on UHC. Here you'll see two Lancet pieces. The first by former Prime Minister Abe, the second by former Prime Minister Kishida, around the time of the G7 Nagasaki, the G7 Hiroshima summit. It's very rare to see heads of government writing articles in the Lancet, and it's really thanks to Japan that universal health coverage entered the SDG era, and then subsequent actions, the Iseshima summit, G7 summit in 2017, and the UHC Knowledge Hub that's coming in 2025. So it's important to acknowledge how much Japan has to put this on the agenda. But what does that mean for the HIV response? And it should be a good thing, and it is a good thing, to integrate the HIV response into broader health systems response. It's a good thing from the perspective of a person accessing the services, because you don't want to have to go somewhere for your HIV and somewhere else for your diabetes and somewhere else for your tuberculosis, right? it's good to integrate into broader health systems. It's also good for economic reasons because you don't want to duplicate. But somehow the words UHC or the letters UHC strike terror into many HIV advocates' hearts. And the reason is really about this one word, equity. And you can read the quote there. The quote is from a joint UNAIDS and PEPFAR report in 2024, long may PEPFAR live. Because often when countries or people talk about UHC, they say, well, we have a national insurance scheme. That's UHC. But that's one dimension of UHC. And so there's a real fear that as we move to these broad-based general health system responses, we lose the particular responses to HIV, which are around equity, human rights, key populations. And that's a real challenge for advocates, and that's something we need to fight for in the UHC that we want. I draw your attention here also to a guidance note from the Global Fund. Again, all this will be available to you about the importance of integration, but again, stressing the equity dimension. The one good thing, well, there are many good things, but one good thing that the UHC discussion allows us to have is that it removes kind of the barriers between donors and implementers or recipients, because every country is on the road to UHC and no country has fully realized that promise. And to illustrate that point, I started talking about my own country, and I could make many comments about my own country about what needs to improve, but I'm now going to talk about Japan, which, as we heard from Ambassador Nakamura, has had a universal health coverage scheme since 1961 and is really seen as one of the leading lights in global health and in the UHC movement. So I was a little bit surprised. I had the great opportunity to meet with community advocates in last November when I was here in Tokyo. You might recognize some of yourselves in those photos. To see this data about trends in new HIV and AIDS cases in Japan, and something didn't look right, because so this big black bar at the bottom, let me see if I can use there we go, is the number of AIDS cases, AIDS, full-blown AIDS, about 300 a year. And so I thought, why in a country which has a health system so developed and which is such a leader in global health, why are people getting full-blown AIDS still? And I asked the community advocates, and they said it was a few things. They said it was, well, people can't really access PrEP when they need it. They said that it takes quite a long time sometimes to get on treatment. And they said that there's a real issue about funding for community organizations. And all of those things are things that can be addressed and should be addressed. Because remember, global health isn't just public health happening in faraway places. Global health is also what's happening here and in every part of the world. And so just as Michelle Sidibe issued a challenge to Sydney in 2010, the duty falls on me to issue a challenge to Japan today and say that actually your goal is zero AIDS cases, and this is achievable. And I'm going to be even a little bit more ambitious, because remember, this is 2025, not 2010, and that we do have PrEP and treatment as prevention and U equals U, and actually say that your goal should be zero HIV notifications. You won't know how close you can get unless you make a bold commitment. And it's going to require strong government commitment. It's going to require ready access to PrEP, ready access to treatment, and really sustainable funding for community organizations who are the last mile, who can reach these people who aren't going to get tested until they have full-blown AIDS, right? They don't go to government doctors, they come to community. I was talking with Iwahashi-san, and we worked out that my organization, one organization, receives 20 times the funding from government for HIV services than the entire community sector in Japan. And I think we can do something about that. So this is my challenge to Japan today. We know you can do it. We're your friends and admirers, and I genuinely mean that. Friends and admirers will be walking alongside you and cheering when you do it, and we look forward to seeing your progress.
Yeah.